Okay. So great. Good morning, everyone. And for those of you attending from outside of the US, good evening. Welcome to the AAP section on neonatal perinatal medicine, TCAN 52 in 52 RCT Challenge Virtual Journal Club session. Thank you for joining us today. Housekeeping announcements. If you're not speaking, please mute yourselves. Please send your questions to either me, Sai Muktapuram, one of the hosts for this afternoon. I'm a neonatologist at Cincinnati Children's Hospital, or Viral Jain, who's a neonatologist at University of Alabama, my co-host for this afternoon. And also at the end of this presentation, please fill out the feedback survey to help us improve our future sessions. Our presenter, our faculty mentors, and moderators may pause the presentation for questions at any time to make this an interactive and an educational session. The trial we'll be discussing this afternoon is the controlled trial of 2 incremental feeding rates in preterm infants by the SIFT group of investigators and led by Dr. Dorling, who's also one of our faculty mentors for this presentation today. This paper will be presented by Dr. Kristen Riley, a second-year fellow at the University of Illinois, Chicago. We are now excited and honored to introduce our faculty mentors for this discussion, and we thank you on behalf of TCAN and Section of Neonatal Perinatal Medicine for agreeing to participate in this session. First, I would like to welcome Dr. Poindexter. Dr. Brenda Poindexter is a professor and the chief of Division of Neonatology at Emory University and Children's Healthcare of Atlanta. Dr. Poindexter has been an inspiring leader with several contributions to the NICHD and NRN trials and has authored several publications in the nutritional arena. I also have the privilege of training under Dr. Poindexter and directly witnessing her passion for neonatal nutrition, mentoring trainees, and also practicing evidence-based medicine. So thank you, Dr. Poindexter, for joining us today. And then it's an honor to have Dr. John Darling, who is a professor of pediatrics and a consultant neonatologist at the University of Southampton in the UK, and has successfully led several trials, and including this trial we'll be discussing today. Thanks, Dr. Darling, for joining us this afternoon. And now I will poll our audience to gauge a sense of what their feeding practices in their units are pertinent to this topic of discussion today. Audience should be able to see a poll right now. In infants less than 32 weeks gestational age at birth and or less than 1,500 grams at birth, what is your typical practice of daily feeding advancements? I will give about another 15 seconds before I end the poll. Great. So we have most of our audience picking either 15 or 20 ml per kilo per day feeding advancements daily. And with that, I will have Dr. Riley share her screen and lead us through this discussion. Dr. Riley, please go ahead.
Can you see my slides?
Not yet.
It's saying that it's disabled for sharing.
Oh, that's right.
Okay, how about now?
Yes.
we are able to see your first slide. Okay. Yep.
Perfect. Thank you to TCAN for the opportunity to present today. To the mentors for this discussion, Drs. Dorling and Poindexter, and for my clinical mentor, Dr. Romano Keeler, joining today, who also researches NEC, and my current program director, Dr. Pillars, and the faculty and people I've worked with during my fellowship training. Today, we will be discussing a controlled trial of 2 incremental milk feeding rates in preterm infants, the SIFT trial. I have no conflicts of interest to disclose today. I wanted to start off by talking about some background and why this topic is so important. So earlier rapid feeding advancement in stressed infants could increase the rates of necrotizing enterocolitis, decrease length of stay, and decrease indwelling catheter days. Slow feeding advancement is associated with decreased risk of NEC, but may increase the risk of infection from prolonged use of central lines. Existing trial data is insufficient to demonstrate whether slow or fast advancement of feeds affects the outcomes of preterm or very low birth weight infants. Necrotizing enterocolitis, as you all know as neonatologists, is a major cause of mortality and morbidity in newborn infants. NEC is the most common gastrointestinal emergency in newborns. The prevalence is about 7% in neonates less than 1,500 grams. In the SIFT trial, it was about 5% in each group of infants. The mortality range from NEC is 15 to 30%, and there's significant long-term neurodevelopmental morbidity associated with it. Infection and NEC remain predictive factors for long-term disability as well. These factors are strongly associated with brain damage, poor brain growth, and poor long-term outcomes. The results of the EPICURE 2 study comparing extremely preterm infants born in 2006 and 1995 indicate that although survival has improved, about 1/3 of survivors are affected by moderate or severe disability at 2.5 to 3 years of age. Many previous studies have been done, as you know. So I'm going to be looking back historically as far back as 1978 at one of the JAMA articles. And this study was done at Mount Sinai. And then more recently, I'll be discussing a Cochrane review. So this first study back in 1978 at Mount Sinai was a conservative feeding approach. NEC decreased from about 4 cases per year to 1 case over the same time period after a cautious feeding approach in infants at risk for gut ischemia. In infants who were at risk for having gut ischemia from hypoxic injury, and anybody who had encephalopathy, for instance, they really didn't feed infants much at all in the first week of life. They said this was a religious but not a fanatical approach, but it was pretty conservative. And then looking at the Cochrane meta-analysis, this was a randomized or quasi-randomized controlled trial that assessed the effect of slow versus faster advancement of enteral feed volumes upon the incidence of NEC in very preterm or very low birth weight infants. 9 randomized controlled trials were included here with 949 infants. Most participants were stable preterm infants with birth weights between 1,000 and 1,500 grams. The trials typically defined slow advancement as increments of 15 to 24 ml per kg per day and faster as 30 to 40 per day. Meta-analysis did not show statistically significant effects on the risk of NEC or all-cause mortality. Slow feeding advancement delayed full enteral nutrition by 1 to 5 days and increased the risk of infection. So before the SIFT trial was done, here you can see that there was an increased risk of infection that was found in this Cochrane review. I wanted to ask Dr. Poindexter to intervene right now to talk about some of the other historical feeding shifts that we've seen over the years.
Sure, Kristen, thanks for that beginning overview. And I would love to hear, John's perspective too. But I think 10, 20 years ago, we not everyone was as focused on nutrition. And I think that some of the work that came out of our NICHD glutamine trial really showed that for many clinicians that perceived severity of illness influences decisions made about nutrition, with the most critically ill babies often being the ones most vulnerable to receive suboptimal nutrition. And so I think one of the biggest changes just in the last even 5 to 10 years is the recognition that having a standardized feeding protocol is very, very helpful to sort of keep that focus on the importance of nutrition and sort of take away that perception of babies being too sick to receive enteral nutrition. I think that, for me, one of the most fascinating things about, some of the literature on standardized protocols is that just simply having a protocol seems to be more important than what the individual components are. And so, I think this is why I'm so impressed with the SIFT trial, is that it's sort of taking one piece of what might be included in a standardized feeding protocol, and that being the rate of advancement of feedings, and sort of, trying to dissect what's the evidence, for that. And hopefully, people can continue to do studies like this where we can really fine tune those various aspects of feeding protocols. I think the other two things that, sort of immediately come to my mind is that compared to the studies you presented, we're taking care of babies born at much earlier gestations and with much lower birth weights. And those babies, unfortunately, have just not been as well represented in any of our, nutrition or growth studies. And then I think the more recent shift to recognizing the need to use donor milk to prevent NEC as a substitute, when mother's own milk isn't available, I think is a huge shift. And, the number of our very preterm babies receiving exclusive infant formula diet, I think is as close to zero as I can imagine in most parts of the US at least. And I think that I think you'll probably get into that subgroup from John's study, but I think that has been a major shift in how we feed babies. John,
Thank
do you
you.
have other thoughts about changes?
So it's probably worth saying that SIFT came out of the previous study, which was ADEPT, where we took babies with small for gestational age and abnormal Dopplers, and we fed them on day 2 or day 6. And that didn't show much of a difference between those two, but the babies fed on day 2 could get to full feeds quicker and had slightly less jaundice and other complications too. So this grew out of that, and we thought we could try and produce a trial with 2 different feeding speeds, and we managed to do that quite well. I think there are some differences between the UK and the US. So in the UK still, but certainly when we did SIFT, there were lots of babies having formula feeding, as you'll see when we go through it, and that's quite important. And we still don't have widely used prolactin, so human derived fortifiers. We still use mostly cow's milk derived fortifiers in the UK, which is a difference with North America, I think. So it's quite interesting to compare. But there's some important messages here, I think, so it'll be interesting to go through those. Thank you.
I just wanted to, John, it's a great study. And I just was going to add one quick thing because Kristen is going to bring up our feeding protocol here at UIC at the end, which includes some of the ways that we dissected the SIFT trial as an institute and tried to create our own feeding protocol. What I've personally seen historically as a gut microbiome scientist who started when the Human Microbiome Project evolved in 2006 is there became a bigger impetus to move feedings forward to promote gut colonization, particularly with breast milk and not with formula. So my approach now, as we at our institution finalize and implement a feeding protocol, is trying to balance the many risks that we've known for years with fast feeding advances in stressed infants with what we know as scientists is the bacterial colonization that has to happen initially, that is often abbreviated when babies are born early. And while we're getting better at doing that with donor milk and potentially probiotics, these feeding protocols, along with the antibiotics that we use quite a bit in the NICU, are often working against the success that we can have on these feeding protocols. So I can tell you, trainees, as a neonatologist for many years now, that's where my mind has shifted to how can I get babies their gut bacteria while still feeding them safely.
Thank you all for your comments. So as we discuss this trial today, we're going to be moving through the Consort 2010 checklist of information to include when reporting a randomized trial. And in speaking with Dr. Dorling, these criteria were used in writing up this trial. Starting off by looking at the title of the study, the title does define that it is a controlled trial. It doesn't have the word randomized in it, but as you read through the abstract and methods, you do realize this is indeed a randomized controlled trial. And then looking at the abstract clearly defines who was included in the study, the number of patients, and the number that were randomized. The authors clearly state there were no significant differences in outcomes, and we'll talk about what those outcome measures of primary and secondary outcomes were in just a moment. And then they also looked at NEC and late onset sepsis as outcomes and compared those. So I think the abstract did a good job of explaining what the study was, who was included, what they found, and the most significant results. Dr. Dorling, did you have any other comments on the writing up of the protocol with the Consort checklist?
No, that's fine. Obviously, when you submit a paper to the New England Journal, they get quite involved in editing it. So what you see is the agreed final version. So I think we did have randomized in the title to begin with, but after all the edits, it came out.
Okay. In terms of the introduction of the paper, some observational studies are mentioned, which have shown a higher risk of NEC with rapid advancement of feeding volumes, but those can be subject to bias. And slower feeding advances might increase the risk of late onset sepsis, as we talked about, from longer exposure to parenteral feeding, as shown in the Cochrane meta-analysis that revealed no increase in NEC. So what are our knowledge gaps in terms of this area of infant feeding? So one of them that was looked at in this paper was, are long-term outcomes of preterm infants different when receiving slower versus faster advancement of feeds? Now we're going to be moving in to talk about the methods. So this was a multi-center study. Patients were included if they were less than 32 weeks and less than 1,500 grams, receiving less than 30 ml per kg per day at study initiation. When clinicians were ready to start advancing feeding volumes, infants were randomly assigned to receive daily increments in feeding volume of 30 ml per kg in the faster increment group or 18 ml per kg in the slower increment group. An infant was considered to be at full enteral feeding volume if at least 145 ml per kg per day was administered for 3 consecutive days. I wanted to pause here and ask Dr. Dorling if he could interject with whether you used donor breast milk in terms of fortification and when that's done at your institutions that were involved in this study, and whether probiotics are used in a common practice for you.
Okay, so what we did was we simply specified the feeding increments. We didn't provide guidance or specified what they should get. So people were able to use donor breast milk if they did in their units. They were able to use Fortifier when they normally did, and they used probiotics if they normally did. What I can say though is very few units when we ran the trial were using probiotics. Some were, but not many. Fortification was quite common, but in general back then it was very common in the UK to wait till the baby was on full feed, so 150 mils per kilo before starting it. There were a few sites that would start it a bit earlier than that, but in general, when we did SIFT, people were fairly late to that. There's some information on, might not be donor milk, but it's breast milk later on that comes up from the tables. But donor breast milk wasn't widely available when we did SIFT. It's become much more available in the UK since then, but it wasn't widely available then. So, yeah.
Great. Here we're going to look at the trial flow diagram. This is in the supplemental materials for the study. We talked about the eligibility criteria. This was infants less than 32 weeks or birth weight less than 1,500 grams. Written consent was obtained from the parents. Infants were excluded if they had severe congenital anomalies, no realistic chance of survival, or if they were unlikely to be traceable for follow-up. Randomization was done in a 1-to-1 allocation ratio, and this was done by a secure web-based randomization into the two groups.
And just to, Kristen, if I may pause, just to tag along to your previous questions, what were the practices like at the sites where the study was conducted with trophic feeds or the feeds during the first 3 days of life? As
again, we didn't specify what people should do, but it was pretty common practice to use trophic feeds for at least a day or two. I think it's fair to say that back then the UK was feeding more earlier and more volumes than probably the States in general. But yeah, most people were using trophic feeds, and colostrum was fairly common then as well.
Thanks, Dr. Rodman. Yeah. Okay.
So going back to our flow diagram, we have the two groups of infants and the two different feeding groups. The intervention was that feed should be advanced at the allocated rate as soon as possible after randomization took place until full enteral feeding was established. Some baseline data was collected, including the type and quantity of milk given, the episodes of infection, whether antibiotics were administered, and any major morbidity and mortality. We're going to talk about the outcomes until hospital discharge in just a moment. And then follow-up was at 2 years, and this was the neurodevelopmental outcomes were assessed by this parent report questionnaire, and this was the primary outcome.
Dr. Poindexter, would you mind providing your comments and thoughts on the primary and secondary outcomes used for the study, and same question to Dr. Dorling after?
Yeah, I mean, I think that it's so rare for a nutritional intervention study to be powered for neurodevelopment, and I think so. I applaud the investigators, for that, because I think too often we get sort of sidetracked, by the short-term outcomes. So I think this is a, it really gets to the heart of what is likely to be most important to families and to us as clinicians.
Great, thank you, Dr. Poindexter. So the primary outcome was looking at moderate or severe neurodevelopmental disability, defined as moderate or severe visual impairment, moderate or severe hearing impairment, moderate or severe gross motor impairment, or moderate or severe cognitive impairment.
And
We're going to be,
Can I
yeah,
ask
go ahead.
John a quick question about that? So,
Sure.
you know, with most of the trials conducted by the Neonatal Research Network here in the United States, sort of that composite of neurodevelopmental impairment includes the things on this slide, but it also includes a diagnosis of cerebral palsy. And I wonder if you could comment, and maybe that is somehow captured with that gross motor impairment, but maybe just to talk about why the decision was made to not include CP in the composite outcome.
Sure. So obviously cerebral palsy is really important, and it's very similar to this definition. I think the big reason it wasn't part of it is it requires a medical examination, whereas we were going with a parent-reported questionnaire. So we did ask whether the baby had been diagnosed as having cerebral palsy, and you'll see that in the results. But we didn't do examinations because it wasn't feasible with so many babies. So that's why it wasn't part of the primary outcome.
The PARCA-R scores are recommended to screen for developmental delay in children born preterm. So again, these were reported by the parents for their children. The questionnaire comprises items to assess sensory impairment, motor, and cognitive function. The total score can range from 0 to 158. Lower scores mean greater impairment. So scores less than or equal to 44 were used to identify children with moderate or severe developmental impairment. This questionnaire has shown to have at least 80% sensitivity and 80% specificity for identifying children with scores less than 2 standard deviations on a gold standard developmental test. And it is now a validated tool for assessing neurodevelopment in children in the UK. As you know, there's no standardized scores that exist for comparing a child's developmental status with that of the norm, which affects the ability of the PARCA-R to identify children with subtle delays and quantify progress across the full spectrum of development. The norm tables, as you can see, one on the right-hand side of this slide, were produced for obtaining standardized scores from PARCA-R raw scores, and they were done separately for boys and girls in 4 different age groups. So they looked at between 24 months and 25 months, and then 25 to 26 months, and 26 to 27 months, for example. And so the first column, you can see the raw score. It's compared to a standardized score, and then you can see the confidence intervals. And I wanted to see, Dr. Dorling, if you had any comments on this tool being used.
Not really, only when we used it, it was, as you say, for screening, which I don't fully understand this, but I think means you get more babies diagnosed as having a problem compared to if you did a formal examination and a baby score, for example. And I think this work that you're presenting has happened since we used it. So there's been more work on it, and it's probably a better test now than it was when we used it.
Thank you.
John, could I also just ask, to piggyback on that, what is your patient population like in terms of the education level of the parents who would have been answering the survey, and their ability to complete it? Just curious,
Sure.
because we've used other parent surveys in our unit and struggled with some of the issues you'd expect with it.
So you've caught us out because we didn't actually collect educational details of the parents, unfortunately. And that's obviously an important issue. In general, the UK educational system means that most parents are able to answer these questionnaires and respond. There's clearly a concern about some of the less well-served populations, so some of the ethnic communities might not be able to answer it quite as well, especially when there are language issues. So there probably is an important issue there. Obviously, we wouldn't expect the difference between the two arms of the trial. And we'll come on to the numbers that responded in a bit. We got good response rates in general, but you do wonder about the ones that you don't get a response from.
Great, thank you. So there was an endpoint review committee. This endpoint review committee was blinded to study assignments. However, the providers and families were not blinded, since it's difficult to hide that from the people who are administering the feeds to these infants. And this endpoint review committee confirmed the classifications of the moderate or severe neurodevelopmental disability, late onset sepsis, and NEC. Now we'll talk about the secondary outcomes, one of which, as Dr. Poindexter pointed out, is the diagnosis of cerebral palsy. So that was one of the secondary outcomes of this study. They also looked at death before discharge, late onset sepsis, NEC, time to reach the full feeding volume, growth, the duration of parenteral feeding, the duration of intensive care, the duration to discharge home, and then the outcome of neurodevelopment. In terms of the statistical analyses, these were pretty involved for this study, I would say. They used an inflation factor of 1.12 to allow for multiple births. So they were trying to look at how likely, for instance, if there were twins, how likely they were to have the same outcome. And this adjustment assumed the percentage of multiple births to be about 25%. They used an intra-class correlation coefficient for the primary outcome at 24 months, corrected for gestational age. The demographic factors, clinical characteristics, and outcomes were summarized with counts and percentages for categorical variables, means and standard deviations for normally distributed continuous variables, and then medians and interquartile or simple ranges for other continuous variables. The outcomes were analyzed on an intention to treat basis. 95% confidence intervals and risk ratios were used for the primary outcome and discharge outcomes, and 99% confidence intervals were used for dichotomous variables. That would be multiple variables. Dr. Dorling, I know you had a comment on the use of the 99% confidence intervals that were done here.
Yeah, so we used 95% for the primary outcome and for NEC and late onset sepsis. For everything else, we used 99% confidence intervals. And that was an old-fashioned approach to trying to allow for the fact that we were doing so many comparisons. So we're doing multiple comparisons, so we reduce our confidence intervals by using 99% instead of 95. Reduce, widen. But the important thing, nowadays, people tend to use a formal correction, so they'll use something like a Bonferroni correction where you adjust your p-values and so forth. Instead, it's just a different approach, and it has slightly gone out of favour, but it's quite important when we look at the results.
John, can I also ask about the intent to treat analysis, and if you also did a per protocol analysis, and if they were different?
So the answer is we definitely did an intention to treat, and I need to go and have a look at the summary additional paperwork. I can't remember now. That's terrible. I'm not sure we did. I don't think we did do a per protocol analysis, but I'll have a look whilst you carry on.
Just going back real quick. So then the adjusted risk ratios were estimated with the use of log binomial regression or log Poisson regression with a robust variance estimator if the binomial model failed to converge. And linear regression was used for normally distributed continuous variables and quantile regression for skewed variables. So the quantile regression was used instead of Cox regression to analyze the time to full feeding volumes. That was because the Cox proportional hazards assumption was not satisfied. the Cox proportional hazards assumption states that the hazard ratio is constant across time. And if this assumption of constancy over time does not hold, then it cannot be used. A subgroup analysis was done as well, and that was looking at the consistency of the effects of advancing milk feeding volumes on the incidence of the primary outcome, late onset sepsis, and NEC across subgroups based on gestational age, birth weight, and type of milk. And that was assessed with the use of the statistical test of interaction. And this can be seen when we discuss the results in figure 2 coming up. Going back
Just
to our
say we didn't
Sure.
we didn't do per protocol analysis. I'm sorry, we didn't do it, and that's partly because there are a fair number of babies that didn't get their allocation, and it can be stopped for a bit. It's just extraordinarily complicated how you do it. We could have looked at a small proportion of babies that did get the allocated amount, but it's just a very complicated dynamic process feeding a baby over a period of time.
Going back to our checklist, looking at the methods. So the description of trial design, including the allocation ratio. This was, as we talked about, a computer generated allocation with a parallel design. The important changes to methods after trial commencement. They talked about using the quantile regression instead of Cox regression. And the eligibility criteria for participants was well defined. The settings and locations where the data were collected, this was multi-center. And then interventions and when the trial was started, they talked about how when they were ready to start the feeding advancements, that's when patients were allocated or were assigned to the groups. And then I believe the outcomes were also well defined. In terms of the changes to trial outcomes after the trial commenced with reasons, they did go back and do some additional analyses to look at infants who had reversed end diastolic flow and absent end diastolic flow, and then how sample size was determined. And they have a whole paragraph in terms of the sample size in which they talked about the number that would be included.
The bit about when people were ready to start feed advancements, that's because we were worried that if we did it early in the baby's course, say you were allocated to the fast feeding group, that we thought there might be some clinicians that would wait before increasing the feeds. So we were worried that there might be different application of going up on the 2 feeds. So that's why we did that. And it seemed to be effective.
And John, just to clarify, when you did have multiples, they were on the same advancement, or they were?
They were.
Okay.
They were on the same, and that's because that was kind of after we planned the trial. We spoke to parent and patient involvement groups, PPI groups, and they very strongly wanted the babies to have the same allocation. So that's what we did. And that's why we increased the sample size by that 1.12, which is based on the correlation.
In terms of the randomization, they said will ensure balance on important prognostic factors using a minimization algorithm to include the collaborated hospital, gestational age, and birth weight. And we talked about the blinding and the fact that the providers were not blinded, but the endpoint review committee was blinded. And then looking at statistical methods used to compare groups, we discussed some of those already, and the methods for additional analyses such as subgroup analyses, and that was done for gestational age, birth weight, and milk type. Now I'll be moving on to discuss some of the results of the study. So starting out, they had 2,804 infants that underwent randomization. 1,400 were assigned to the faster feeding increment group, and 1,404 were assigned to the slower feeding increment group. Some patients had withdrawn consent, and additional patients were either withdrawn or discontinued from the interventions. And then in the faster feeding group,
All right,
they had six.
Kristen,
go ahead.
can you clarify if they talked about the reasons for withdrawal or discontinuation?
Dr. Dorling, do you have more information on that?
I can't remember the numbers now, but it was due either to the parents not wanting to be part of the study or occasionally to clinicians. So you can see, and in fact, you can see it in there. So 29 were withdrawn in the fast group and 37 in the slow group. And it's just 6 had consent withdrawn and 5. But that means that the others, we were able to use their data. It's just those 6 and 5 where the parents said we couldn't use their data anymore.
I know they discussed in the paper that if the clinicians had concerns about the patients clinically, that they would withdraw in that sense too.
So, Dr. Dorling,
usually we allowed them to withdraw the intervention, but the baby still stayed in the study.
Okay.
Sorry.
Dr. Dorling, we have a question from audience. Wanted to know how many of the babies were actually eligible and how many of those got randomized.
We did look at this, and I can't honestly remember. So you can see the number that were randomized, 2,804, but I can't honestly remember how many more there were. I'd be guessing, but I think it was something like a half of the babies in each of the units. It's that sort of figure that took part.
Thank you. So,
Kristen, one
go ahead.
regarding the faster versus slower feeding. Like usually you would expect more withdrawals from the faster feeding group.
Correct.
If the slow increments is your usual practice. Like any thoughts on that, Dr. Dorling, like why there were more babies withdrawn or discontinued the intervention on the slower feeding group in comparison to the faster feeding group?
Okay, so the slower group, people would discontinue the intervention because they were having trouble with IV access or lines, that kind of problem. So then they would feed the baby a bit quicker towards the end, but that's still counted as not having the intervention through the whole time of establishing feeds. So that was reasonably common, as you can see. Obviously, the neck results were very similar in both groups, so that doesn't really feed into it. But that's primarily, I think, why the slow group had the intervention discontinued. They just had their feeds increased quicker.
Great, thank you.
So then also excluding infants who had died or had missing data, this left 1,224 in the faster feeding group and 1,246 in the slower group.
Kristen, before we move on, do we have the cause of death for those who died? Just making sure that it wasn't a death related to neck or something that would be germane to the, primary outcome.
I don't know that we do, Dr. Dorling. Did you?
I don't think we analysed it. We might have collected it, but I don't think we analysed it.
That is a good point, though. Okay, so then looking at the characteristics of infants and mothers between groups at trial entry, they were pretty similar. Overall, the median age at randomization was 4 days. The birth weight less than 10th percentile for gestational age was about 20% in each group. The median week of age at delivery was 29 weeks. Birth weights did not vary much at all between the two groups, 1144 and 1142. And now we'll move to speaking about the primary and secondary outcomes that were assessed. So looking at the results in the secondary outcomes of moderate or severe motor impairment, After adjustment for some of the minimization factors, moderate or severe motor impairment occurred in 7.5% of the infants in the faster fed group compared to 5% in the slower increment group, which was an interesting finding. And we're going to talk some more about why that might be the case coming up.
Kristen, I'm sorry to keep interrupting.
No,
but
go ahead.
I would love to hear, like in other studies conducted, you know, in the UK, is the baseline expected rate of moderate or severe motor impairment, does it align with you know, what you found in these two populations, or?
So I think that's a bit high, and it comes back to the Parker R being a screener rather than a developmental assessment tool. So it over-reports the number of babies that might have problems. At least it did when we had the data, when we used it back with SIFT. It's been updated since. So I think it's a little bit high. It was certainly higher than we expected.
And John, sorry as well to interrupt, but when you said that the slow group often withdrew due to IV access, is your unit approach to go with the PIV to Band-Aid the remaining feeding advancement, or to transition to a PIC regardless of what the volume's at, or is it just a case-by-case basis?
It's very case by case. Most units in the UK use peripheral long lines. So they'll start with an umbilical catheter, use that for up to a week, and then move to a peripheral long line, a PIC. Occasionally they'll get a surgical line put in, but that's pretty uncommon.
Thanks.
Looking at some of the other outcomes, so they did find no significant differences regarding late onset sepsis. Although if you look at the two groups, there are slightly more infants who had late onset sepsis in the slower fed group. No significant differences in stage 2 or 3 neck, death during hospitalization, weight and head circumference at discharge, the duration of time in intensive care, and the duration of hospital stay. The incidence of late onset sepsis was about 30% in each group, which Dr. Dorling said they were a little bit surprised to see that level. Dr. Dorling, did you have any comments on that and why you think that might have been the case?
So I think we estimated 25%, so we were a bit surprised to get around 30 when the eventual results came. There's two bits to that. One is we did the whole admission, so the whole time the baby was there. And obviously that's a long time, and it's not very related to the feeds at the beginning. So if I was to do the study again, I'd probably go up to 36 weeks or something like that, rather than the whole admission. And then the actual incidents depend on what kind of babies get into your study, and it's kind of selected by equipoise, so by the clinicians feeling they didn't know the answer to this group. And I think we found that the babies were a bit more, they had lower gestations and were a bit smaller than we expected. We were quite pleased that we got those babies into the study, and a little bit surprised. So they're perhaps a bit higher risk than we thought they would be.
And here we have a Kaplan-Meier curve looking at the feeding, and the infants that were fed faster were reaching the full feeding about 4 days earlier than those undergoing slower feeding advancements. So this is just a visual to show you that in fact it can be done, that the infants can be fed faster.
So you've got about 80% of babies that seem to tolerate your regime, and then you've got the tail of 20% in both, really, that don't necessarily tolerate it very well. So you could definitely do it.
And now we're going to look at the type of milk. In and this was one of the sub-analyses that were done. So between the breast milk only, formula only, or a combination of the two, there were really not many infants, pretty small numbers in the formula fed only group. But there was evidence of a statistical interaction between the type of milk and feeding increment with respect to survival without moderate or severe neurodevelopmental disability corrected for gestational age. And I think Dr. Dorling was gonna insert some comments here in terms of this and being related to some of the motor outcomes that we've seen.
Yeah, so we've done some further analysis on this and looked at that bottom group, the breast milk and formula, for the mixed feeding group, and the association holds. So it's the babies that, it seems to be the babies that are exposed to formula milk more likely to have disability if they're fed fast. You can see that the breast milk only group, it's very much around the line of equivalence, but that formula only group, it's statistically different. And there is an association if you look at the mixed group in more detail. There's some evidence to suggest that breast milk can produce more connections in the brain and can enhance your brain growth and development. So there is a physiological rationale behind it as well. The other thing that we found is the fast-fed group were more likely to receive formula than the slow-fed group. And that's just because the mother couldn't keep up with the demand for the breast milk quite commonly. Obviously not all babies, but that was a more common problem. So to me, in a unit that uses donor breast milk like we do where I work, and like many units in the North America do, you're probably looking at that top line where feeding fast doesn't affect your neurodevelopment because you're on breast milk. So it's quite interesting, really. But that's unpublished data at the moment. I need to get that published.
John, just to be clear, when you say breast milk only, you're lumping together donor milk and mother's own milk into the same group there.
That's right. That's right. Yeah.
Okay. I mean, I think your data on the formula only, I mean, it's very much aligns, with the studies that Betty Vore has published, looking at sort of the dose response improvement in neurodevelopment really for, every ml of human milk that, and this was all mother's own milk, that extremely preterm babies receive. I think the milk trial that was just recently completed, I think will shed some light on whether donor milk confers that same advantage with neurodevelopment as mother's milk. And, my personal bias is that we have a harder time getting babies who receive predominantly donor milk to grow. And so that impact of suboptimal growth on neurodevelopment, also adds a layer of confounding to this. But I think just all the more reason that our efforts need to focus on, getting our babies as much mother's own milk as is feasible.
And I just wanted to add, John, also I applaud you so much on the follow-up of these patients and for trainees. And Brenda mentioned Dr. Betty Vore, but Dr. Vore is known for her great follow-up studies. And I always think of Barbara Schmidt with her CAP trial. So in my mind, having much more primitive studies on this, the fact that this neurodevelopmental data is included, regardless of some of the limitations at looking at it, is just incredible. And I just want our trainees to appreciate that. So sorry, John, go ahead. I just wanted to make sure you know that, but I don't think Kristen and I discussed it, and it's just great to have.
That's very kind. I think the other thing I was going to say is we looked at Fortifier as well, and actually that's protective. So if they had Fortifier, they had better outcomes, and that presumably is related to something to do with the growth of the brain. So very interesting. I need to get that paper out.
Thank you all for your comments on this. So overall, the results showed the speed of advancing enteral feeding volumes did not have a significant effect on the primary outcome of survival without neurodevelopmental disability. There were no significant differences between the groups regarding the individual components of the composite scores of the neurodevelopmental disability. The speed of feeding advancement did not impact risks of late onset sepsis or NEC in very preterm or very low birth weight infants. And for infants fed formula only, survival without moderate or severe neurodevelopmental disability was better in the slower increment group compared to the faster fed group, which we discussed.
So, Dr. Darling, I have a question from the audience for you. Can you comment on your PAS abstract about representativeness of the SIFT study participants according to the gestational age?
I haven't got that to hand at the moment. I think that showed that some of the smaller groups were less represented. So some of the smaller lower gestational ages were less represented than some of the bigger babies. So you can make an inference that the results are more applicable to the larger gestational age groups. It depends how you look at it, and there isn't a hard and fast way to assess it. But as you say, there was more of the bigger babies got into the trial, which is what you'd expect. You'd expect there'd be anxieties about including some very preterm 23 weekers, for example. Yeah, there still were quite a few, so they're probably representative, but to some extent. But yeah, there's a difference across the gestational ages.
Thank you. Kristen, you can go ahead.
Thank you. So this study also did a analysis looking at whether there was the presence of antenatal absent or reversed end diastolic flow and whether this was statistically significant. Dr. Dorling was letting me know that he was receiving questions about this, and so they went back and did some additional analyses. And in fact, there did not seem to be differences amongst the groups in terms of whether this had an impact. So I found that interesting just because I know when we see absent or reversed end diastolic flow, it does oftentimes make us more cautious about our feeding approach. And I know at my institution, it's one of the criteria we use for more slow advancements. Dr. Dorling, do you want to insert any comments here?
Yeah, well, it was interesting, as you say. So for NEG, the table on the right, S2, you can see that there was more NEC in the slow-fed group that also had abnormal Dopplers than there was in the fast-fed group who had abnormal Dopplers. But it's not statistically significant, so you can't really draw too much from it. But we didn't see a pattern that there was a problem, which is quite interesting, as you say.
And then just some questions about the results. What were the practices regarding lines in your unit? For instance, like how long does a typical UVC stay in versus the insertion of a PIC? And then over a broader time period, including the study period, what were the rates of NEC in the units participating? Were they typical, or was there an increase or decrease in the rates of NEC?
So the first one I kind of covered earlier. I think UVC's 7 to 10 days is the longest. Some people take them out a bit earlier, and PICs are very commonly used, and quite a lot of units will change them after 3 weeks, so they won't leave them in for more than 3 weeks. But obviously a lot of the babies got to full feeds before that time frame anyway, so mostly they came out. I think the rates of NEC were fairly typical in the study compared to the unit data that we get. So there's the National Neonatal Audit Programme that gives us unit data, and it's pretty similar. And there has been a gradual decrease in the rates of NEC over the last few years, probably related to the use of donor breast milk and probiotics.
Can you comment on the practice related to my least favorite thing in the world, and that's the measurement of gastric residuals?
Okay. So we've actually got a trial funded. So one of the follow-up trials is to look at that. So in adults, we know that measuring gastric residuals is associated with a lengthening in the time of getting onto full calorific feeding. And there isn't actually any good data in babies that it's a good idea to measure gastric residuals. But as you know, it's an extremely common practice, and we're going hopefully to do a trial where we randomize babies to not have it measured, and then we have other babies where it is measured, and hopefully we'll find out whether it does make any difference, or whether it, as I suspect, just
Hey, John, how quick can you get us those results? You
we
let
haven't
us know
started
when
yet,
those.
so later this year we'll start. Yeah.
I apologize that one of my slides did not show up, but that article from JAMA in 1978, actually one of the things they did was measure the residuals of that study. So the strength of the study, the primary outcome could be assessed in about 90% of the infants in each group, which was really a great number. One of the largest feeding trials that was done is this study, and they had a very pragmatic nature of trial design. They were able to test an intervention in the real world. Looking at some of the limitations, so infants were already a median of 4 days old at intervention, and therefore the trial does not inform us on the relative safety of this feeding approach in the first few days after birth. The caregivers were unblinded. Sepsis was evaluated, as Dr. Dorling mentioned, over the entire admission period, which can bring in other causes of sepsis. And then the PERCA-R questionnaire may not be able to have external validity. Going back to our consort checklist, they asked about the registration number and name of trial registry. So all surviving infants recruited into SIFT were flagged after being discharged home to confirm status using records held and maintained by the Health and Social Information Center. And then the source of funding. Go ahead, Dr. Dorling.
Sorry, Chris, that's asking a different question. That's asking if the trial is registered. So we were registered, I think, with the ISCTRN. So the study and the protocol was registered online, so you can access it. That meant we're much less likely to change our methods during the study. You've gone on to individual patients, which is quite right, but that's not what the questions are.
Thank you. Looking at the source of funding and other support, it was funded by the Health Technology Assessment Program of the National Institute for Health Research. So questions. So one of the things we always like to think about is whether my patient population is different or similar to those in the study, and if this study can apply to my unit. So the study population, as we talked about, had a little bit higher rates than expected for late onset sepsis and a pretty high incidence of multiples, although we know with preterm birth that's more common. So my hospital right now at UIC, we have a pilot feeding guideline that's being used. They're voting on a new version of this that will just go up to about 1,800 grams. But
oh, sorry, Kristen, I just
ahead.
want to make sure, because John and I offline will have to discuss it as we vote. But this, we ultimately, when I came about 3 years ago to UIC, broke up our feeding advancement, which was really quite primitive. And I want that point that Brenda made about, you know, the best thing that you can do to reduce NEC is have a feeding protocol. I think that point that Brenda made is what I've tried to emphasize to our group here. So when I came, we broke up our feeding protocol into trophic. So this is less applicable to the work that Dr. Dorling's done. And then we've had a separate protocol for advancement. I think one of my big questions for you is how to move groups forward with results like you produced in changing the culture of slow versus fast feeding advancements. This trophic feeding chart that Kristen's put up actually took months and months and months to approved, and the advancement now has taken years, literally years, and I'm about to lose my nutritionist if we don't approve this version that we have. But I guess, you know, sort of similar to Brenda's comments, how does new data like yours, which is so comprehensive, does have a lot of strengths, how can those things get implemented successfully with a culture that's sometimes not comfortable with it? And Kristen, I think you have a second slide that shows the exceptions that that were really hard to move folks on. And again, this is trophic, not feeding advancements. But I can tell you, after reviewing your SIFT trial, Dr. Dorling, with the group for I don't know how long, the best we could do, and as Kristen alludes to, it hasn't even been voted on yet. My group has a joke about the virtual celebration we'll have when we do get it approved. The best I could do was have them fortify at 80 to 20. No one is willing to advance faster than 20 cc's per kilo per day. And the 80 to 20 fortification, 80 to 100 fortification range was because folks were still uncomfortable with fortification at 80 and wanted to be able to do it just at 100. And I can tell you that just as recent as yesterday, I received calls from our nurse educator and our nutritionist saying there's rumblings that this is going to come out and people do not feel comfortable with it. And it reminds me of the gastric residual thing we have, where we also at our institute say 40 cc's per kilo per day, consider it trophic, do not check residuals. And all of our fellows know we'll get called that there's abdominal distension. And I know I wasn't supposed to check residual, but we have this residual. So my fear is that even with implementation of a, oh, sorry, go ahead.
No,
how do you get
it? Say we're running out of time, so if we can limit the discussion to the paper and the topic, that would be great. Thank you.
Yeah, well, I guess, Dr. Dorling, how do you get units to adopt your results?
So I think quality improvement programs is the way to move it forward, and having lots of discussion. And I also think SIFT makes it appear that there's just one way of doing things, but actually individual babies, maybe you need to assess how they're tolerating things, and perhaps increasing the feeds a bit more later on if they're tolerating is a good way to go. So I think it makes it appear quite simple when perhaps it isn't.
Wrapping up here, some conclusions and other approaches, as both Dr. Poindexter pointed out and Dr. Romano-Keeler. Evidence supports feeding protocols and guidelines, and when those are followed, lower rates of NEC can be seen regardless of what it says. Just following a guideline is really important. If infants are fed faster, they should probably receive breast milk and not formula, pending further evidence, which we spoke about. Faster feeding can be accomplished, and the speed of feeding advancement did not have significant effects on survival without disability, NEC, or late onset sepsis. I wanted to open up for discussion, any other comments that people have, and future directions.
As we have Dr. Salas from University of Alabama, who's also worked a lot on the trophic feedings topic, we would like to also solicit a comment from Dr. Salas, if possible.
Sure, go ahead.
Thank you. John, well, to follow, it's a great presentation. I always, I've seen progress in standardizing the use of this checklist to analyze evidence. And I think you made a really good job summarizing and dissecting really the trial, and having the lead author is probably kind of the best case scenario to analyze a trial. I think, you know, we discussed about this with John at some point, you know, whether we should actually combine the effects of reducing the reduction of trophics, and then in addition to that, just advance feeds faster is probably the best way to go. As John pointed out, I think we discussed this paper several times in our unit, and it's a bit hard to make the extrapolation to the smaller babies just because of this issue of representativeness. We couldn't agree on 18 or 30 for them. So we just picked the middle number of 25. And so far we've been very successful in achieving compliance. And I think it comes down to what Brenda said about standardizing protocols. And then I think now that the evidence is available, it's just all about QI for implementation.
Thank you so much.
Thank you.
And Dr. Darling, any comments on future trials, or if you would have done anything differently on this trial if you did it again?
So I would have tweaked the length of time to NEC, and well, not necessarily NEC, but certainly length of sepsis, late onset sepsis. So cutting off that time frame. We would have collected more socioeconomic data for the 2-year outcomes so that we could look at some of the confounding factors. Obviously, it's randomized, so there shouldn't be a difference, but it's a bit of a shame that we haven't got more information there. The feeding itself, I think, would be the same. We very much went with the pragmatic approach, so it just looks at the 2 rates. And I think the important thing is we did use trophic feeds, and the median was 4 days, but of course, the smaller babies would have had longer trophic feeds, and perhaps I should have analysed the data and presented that in a bit more information, I think. Yeah.
And Dr. Poindexter, any final comments and take-home messages for our learners here today?
Yeah, absolutely. I mean, Kristen, I would just say what a great job you did, going over this article. It really was outstanding. I think for every trainee on the phone, I think, going back to look at your institution's feeding protocol, and I think rather than trying to adopt an all or none, I think looking at what group could you introduce this practice into in a way that is supported by the evidence and isn't going to create tremendous amounts of angst in your unit. And so, most feeding protocols are for babies 1,500 grams or less. And I don't think anyone thinks that a baby that's 1,499 grams isn't very different from one that's 501. And so maybe thinking about, do we need to not overcomplicate things, but do we need to think about having different arms of the protocol for babies that are bigger and more mature, or perhaps that we know are not going to be getting a predominantly human milk-based diet? I'm really interested in, should we have different protocols for those that are growth restricted? And then I think, as you're implementing, I think, one of my former colleagues in Cincinnati, Heather Kaplan, in thinking about QI taught me a really important lesson, and that's to listen to the people that deviate from the protocol, because it's usually not that they're just wanting to be non-compliant. It's because they have a genuine concern, and maybe that's something that we can learn from. And so, for those babies that, didn't adhere to the protocol, try to find out why, because maybe there's learning there. But great job, Kristen, and great job with the study, John. I think it's really a feat to have this many babies that you randomized in such a cool nutrition study. So congratulations.
Fantastic. Thank you ever so much.
Great.
Thanks, Kristen. It was great.
And thank you all for your participation.
Yeah. And
Today.
John,
sorry, go ahead.
No, John, would you be willing, and certainly I don't know how much you'd like to share it, but would you be willing to share the QI tool that you're now using as you maybe institute changes from what you've learned in the SIFT trial? And perhaps as part of that, you also include how to use it and who's doing the QI data collection, because those practical pieces, as I think all of Brenda and you have said, seeing how it works is part of whether or not you've put in the best protocol. And that's another piece that I think many of us, including myself, struggle with.
Sure, yeah. Or offline another time, yeah.
I just wanted to echo Dr. Poindexter's comments and everyone's comments on how fantastic job Kristen has done. And I can't thank Dr. Dorling and Dr. Poindexter enough for providing their insights and sharing this wonderful trial with us. Thank you everyone for joining and for your time. We really appreciate it, and our learners certainly appreciate it more. So thank you.
Thank you again.
Thanks, Sai.
Thanks very
Thanks,
much.
Carol. Bye-bye.
Thank you, everyone.
Bye, everyone.